The topic of my presentation today is entitled Enhanced Recovery for Neurosurgery, with a primary focus on surgery for brain tumor resection. The burden of disease is actually not small. In the United States, the incidence of brain tumors is 12 per 100,000 person years, and surgery for brain tumor is associated with a significant postoperative incidence of complications, ranging from stroke to myocardial infarction to infection and mortality. More than 6% of patients require a reoperation, and these surgery are also associated with greater risk of postoperative cognitive decline and decreased in functional status in the long term. So how can ERAS protocol help these patients? ERAS, or Enhanced Recovery After Surgery, was first mooted by Henrik Kellett in the 1990s as a multimodal approach to improved postoperative physiology and rehabilitation. It consists of multiple components of care targeting the reduction of stress and the reduction of immune response and pain, and also the minimization of catabolism after surgery. Hopefully, these then translate to real-life patient-centric outcomes. This is an overview of the entire process ranging from the pre-hospital and immediate pre-operative phases to the intraoperative and postoperative and then post-discharge phases. I will pick a few important processes to elaborate. As an overview, I will cover the current landscape of clinical trials, how surgical procedural innovation and improvement in anesthetic techniques play a big part in enhanced recovery after surgery, and finally also whether our anesthesia or anesthesia drugs use affect longer-term outcomes in terms of tumor recurrence. That is probably what matters most to patients, whether or not they can get improved disease-free survival. But it is probably not easy to prove the superiority of any one anesthetic technique over another in this aspect. Just a little bit on history. Trephination or burr surgery under awake craniotomy started in the medieval times. It is the oldest surgery for which there is archaeological evidence. Also, although ERAS first took off in a big way for colorectal surgery, you could say that ERAS for neurosurgery started way long ago. Of course, there are also enhanced recovery protocols for spine surgery, but I will just concentrate on ERAS for oncologic craniotomies. I refer next to this review article on ERAS for oncologic craniotomies. Similar to the general ERAS framework I showed earlier, ERAS for craniotomies cover guidelines on best practices for preoperative counseling, preoperative cessation of smoking and alcohol, avoiding excessive prolonged preoperative fasting, the use of regional anesthesia such as scalp block, and the use of opioid minimization or opioid-free techniques, routine post-op prophylaxis with dexamethasone or 5-HT3 antagonists, and also routine cefazolin antibiotic prophylaxis. It is also important to avoid hyper and hypothermia, as well as to avoid unnecessary usage of lines and tubes. There is also a mention on minimally invasive surgical technique where feasible. This is a neurosurgical trial which shows the safety and efficacy of a neurosurgical enhanced recovery protocol after elective craniotomy. The neurosurgical ERAS protocol has shown to result in shorter median length of stay, milder postoperative pain, and a shortened duration of pain. The time earlier taken to receive fluids and solid food was also much reduced compared to conventional management. In this table, there's also a tendency towards secondary outcome reduction of infection, respiratory complication, and deep vein thrombosis, although the reduction of these secondary outcomes did not achieve statistical significance. So here, just to recap the components of ERAS for neurosurgery, and I will select a few to elaborate further. Firstly, improvement in surgical techniques are very important to enhance postoperative recovery. The development of more advanced neuroimaging technology has enabled minimally invasive and targeted craniotomy, which results in better outcome for patients. In my hospital, for example, the neurosurgeons have started to use brain path, which is a minimally invasive technique to remove intracranial hematoma. The conventional removal of intracranial hemorrhage, as shown on the topmost slides here, usually result in a lot of collateral or surrounding damage and edema. However, the brain path technique results in less surrounding damage, such that in almost all cases, the bone flap can actually be put back. These pictures show the path to least damage while evacuating the intracranial hematoma. Next, a mention on the anesthetic technique of awake craniotomy, whereby we uphold the principle of less is more. This is a picture of craniotomy done in the medieval ages, not much different from current modern awake craniotomy. Traditionally, awake craniotomy is performed to resect lesions near functionally important or eloquent areas of the brain, such as the motor cortex or speech area. By keeping the patient awake or consciously sedated, brain mapping is facilitated and tailored resection can be achieved to minimize postoperative neurologic deficits. Currently, some centers are using awake craniotomy on an extended or expanded indication, regardless of the location of tumor. There is even a call to make awake craniotomy more routine, as less is more. More can be achieved by lesser amounts of drugs given or using ultra-fast offset drugs and avoiding unnecessary lines such as invasive lines or urine catheter, since a general anesthesia is avoided. So just to recap the principles of awake craniotomy, usually minimal sedative drugs which depress wakefulness are used, thus allowing for intraoperative neurologic monitoring. This also then facilitates faster recovery after the surgery. A very limited craniotomy aided by neuronavigation results in much less surgical trespass, and we also often use ultra-fast offset drugs. This again enhances neurologic recovery. Again, in the process of awake craniotomy, we avoid unnecessary invasive lines and tubes. Next, a mention on opioid sparing or even opioid-free anesthesia for craniotomy. Using less or absolutely no opioids is advantageous because miosis, postoperative nausea and vomiting, postoperative hyperalgesia, CNS and CVS and respiratory depression, post-op cognitive deficit, and more recently an association with tumor, angiogenesis and recurrence of the tumor are of major concern with opioid use. The crucial anchors of opioid-free anesthesia are local anesthetics and a scalp block, dexmedetomidine infusion, and other analgesic adjuncts such as paracetamol or maybe even NSAIDs and ketamine in some centers. Hence, there is now a paradigm shift. Opioid analgesics should be used as rescue therapy rather than routine therapy. Many different protocols have been described to achieve opioid-free anesthesia with or without local regional blocks for various different types of surgery, including major cancer surgery. There is now a new paradigm in the analgesic pyramid. Opioid-free anesthesia represents a refreshing wind of change. In the old way, opioids formed the foundation of our analgesia management. But in the new way, we reserve opioids mainly for severe pain or as rescue therapy. So in my hospital, some of us have started to use opioid-free anesthesia on a routine basis for supratentorial craniotomy for brain tumor resection. Next, how about fast-tracking discharge after neurosurgery? In some centers in North America, in carefully pre-selected patients, it has been shown that same-day discharge for supratentorial tumor resection is feasible, especially since a general anesthesia can be avoided, thus enhancing recovery. As mentioned earlier, in some centers in North America, they actually promote the use of an awake craniotomy technique, not just to avoid a general anesthesia, which then enhances and quickens recovery. It also helps to reduce resource utilization in that there is a lower need for ICU admission, a reduction in hospital length of stay, and generally a reduction in complications associated with a GA. Of course, this requires very careful pre-selection of the appropriate patients. Going back to the question of post-op disposition, do all patients require routine admission to the intensive care unit after elective craniotomy for brain tumor? In fact, it can be argued that if we were able to achieve immediate successful extubation after elective craniotomy, whereby a surgical duration is under 4 hours in a non-prone position, then the patient can be monitored safely in the PACU before being discharged to the neurologic general ward instead of the intensive care unit or intensive care high dependency. In fact, same day discharge for craniotomy, also known as outpatient craniotomy, has been shown to still preserve patient satisfaction and also not result in an increase in complications, provided the patients are selected carefully. Say Same-day discharge is possible after many cranial procedures, for example, stereotactic biopsy, and then as mentioned, supratentorial brain tumor resection, or unruptured aneurysm clipping or coiling, or microvascular decompression for cranial nerve neuralgia. The crucial thing in making this successful is that an early post-op CT scan is performed 4 hours to pick up any early complications such as bleeding. If the patient then has uneventful PACU observation, a good CT scan is able to fulfill standard discharge criteria, then early discharge or even same-day discharge can be facilitated. It has been shown to not adversely affect patient clinical outcomes and patient satisfaction. Finally, a brief mention on whether the anesthesia drugs that we use affect longer-term outcomes such as tumor recurrence and survival. At least in the laboratory, morphine and other opioids have been shown to cause tumor regrowth and metastasis due to neoangiogenesis, amongst other factors, which is why I talked about trying to achieve an opioid-sparing or opioid-free anesthesia technique earlier on. Earlier meta-analysis has also suggested that TIVA propofol, as opposed to an inhalational-based anesthesia, may be associated with better recurrence-free survival and overall survival. However, more recent RCTs do not demonstrate such a benefit when using TIVA. Hence, this area still requires much research into finding out whether or not a TIVA versus inhalational based technique, which is more superior in providing better long-term outcomes, is still very much needed. In conclusion, I would just like to share some personal reflections. Firstly, some ERAS concepts are not applicable to craniotomy. Conversely, there are other unique techniques more relevant to craniotomy. For example, the use of scalp block and also the use of the awake anesthesia technique and also minimizing or shaving to reduce postoperative wound infection. Next, the effect of a bundle of care is often greater than the sum of parts contributed by each single intervention. And finally, for cancer surgery, I think long-term outcomes beyond the more immediate postoperative outcomes like early discharge, long-term outcomes like tumor-free survival are even more important. So thank you once again, and I'll be happy to take any questions, or you could email me at my hospital email if there should be any queries later on. Thank you.